Hi, everyone. I am Teresa, and as Christy stated, I'm going to be presenting this coding workshop for social determinants of health and the new or revised items in sections A, B, and D. I hope that you all did have a chance to view the recorded training video of this same topic, because as Christy mentioned, that webinar did provide the framework and background for this coding workshop. Also, if you haven't already done so, I suggest you get out your item sets in front of you, whether you're in an IRF or an LTAC, to help you follow along in these sections as we go through each data element. I will be letting you know on which page the data element appears in your respective assessment instruments as we go along. So let's get started. I'm going to begin by walking through some coding scenarios based on social determinants of health, or the SDOH data elements, and then work through some coding scenarios for the other data elements that do not fall under this designation. Our first data element is A1005, ethnicity, and this data element can be found on page 3 of the admission section of the IRF-PAI. And in the LCDS, it's on page 3 of the admission assessment. So here's our first coding scenario. A patient was interviewed regarding their ethnic background. They stated that their mother was from Mexico, their father was from Puerto Rico, and they were born in the United States. The patient stated that they consider themselves Mexican, Mexican-American, and Puerto Rican. So based on this scenario and the response choices that you see on this slide, how would you code A1005 ethnicity? Would you choose A, code B, yes, Mexican, Mexican-American, Chicano or Chicana? B, code C, yes, Puerto Rican. C, code E, yes, another Hispanic, Latino, or Spanish origin. Or D, both A and B. And if you would start entering your responses into the polling, we'll just take a few moments to let all of you enter your responses before we move on to the answer. I'm not seeing any come through here. I'm not sure if folks can tell me how we're doing with responses. I know we have 509 participants here, so I expect to see several responses coming in. Okay, I think we can go to the answers. So the answer is choice D, both A and B. Code B, yes, Mexican, Mexican-American, Chicano, Chicana, and code C, Puerto Rican, would be checked. The rationale for this is that the correct coding is that the patient identified that their mother was Mexican, their father was Puerto Rican, and consider themselves as Hispanic of both ethnic origins. Thank you. Looks like 78% of you got that one. Okay, moving on to the next practice scenario. A patient was confused and unable to answer the question related to whether they are Hispanic, Latino, or of Spanish origin. The patient's daughter stated that the patient was born in Brazil and has never considered themselves as of Hispanic, Latino, or Spanish origin. So based on this scenario, how would you code A1005 ethnicity? Would you choose A, code A, no, not of Hispanic, Latino, Latina, or Spanish origin, and code X, patient unable to respond? Would you choose B, code B, yes, Mexican, Mexican-American, Chicano, Chicana? C, code X, patient unable to respond? Or D, code Y, patient declines to respond? And again, I'll give you a little bit of time here. Great. Okay, thank you. Let's move on to the answer. So the answer is code A. No, not of Hispanic, Latino, Latina, or Spanish origin, and code X, patient unable to respond. The rationale is the patient was confused and unable to answer the question. The patient's daughter was available and provided information about the patient's ethnic origin as their proxy. Therefore, the assessor was able to document that the patient was not of Hispanic, Latino, Latina, or Spanish origin. As noted in your respective guidance manuals, when a patient is unable to respond, but the response is or responses are determined via proxy input and or medical record documentation, you're going to check all boxes that apply, including code X, patient unable to respond. And let's try one more example for the ethnicity data element. The patient was just admitted to the facility and after several attempts declined to respond to the question of ethnic origin. And based on that scenario, how would you code A001005 ethnicity? Would you choose A, code A, no, not of Hispanic, Latino, Latina, or Spanish origin? B, code B, yes, Mexican, Mexican American, Chicano, Chicana. C, code X, patient unable to respond. Or D, code Y, patient declines to respond. Can we close the polling, please? Okay. And let's move on to the answer slide. And the correct answer is D, code Y, patient declines to respond. And it looks like a good majority of folks got that one correct. Okay, the rationale for this answer is because the patient declined to answer this question. So when a patient declines to respond, no proxy or medical record documentation can be used to answer the question, even if a proxy or medical documentation exists that would provide the necessary information to respond to this question. So the next data element that we will review is A1010 race. You can find this data element in the IRF-PAI on page 3 of the admission section and in the LCDS on page 4 of the admission assessment. So here's our first scenario on A1010. A patient was just admitted to the facility because they're in the late stages of dementia. Their daughter was assisting with answering some of the assessment information. The patient's daughter stated that their father is African American. So how would you code A1010 race based on this scenario? Would you choose A, code B, Black or African American, B, code D, Asian Indian, C, code F, Filipino, D, code X, patient unable to respond, or E, both A and D? And could we close the polling, please? Perfect. Okay, that's the correct answer is E, both A and D. And again, a good majority of folks got that one correct. So the rationale for choosing code B, Black or African American, and code X, patient unable to respond, is because the patient was unable to respond accurately due to late stage dementia, but the patient's daughter was able to provide the information that their father is African American. You'll notice in your respective guidance manuals that it states if a patient is unable to respond, but the response is or responses are determined via proxy input and or medical record documentation, you're going to check all the boxes that apply, including X, patient unable to respond. So that was a little tricky. Okay, and here's another scenario related to item A1010. A patient was being interviewed regarding racial background. They stated that their parents were from different countries. The patient's father was born in the United States and is African American, and the patient's mother is Japanese. The patient considers themselves to be African American and Japanese. So based on this scenario, how would you code A1010 race? Would you choose A, code B, Black or African American, code D, Asian, Indian, code G, Japanese, code J, other Asian, or both A and C. Going to give you a few more minutes so you can get your answers in. Okay, could we close the polling, please? Okay, great. Oh, 98% of you chose the correct answer, which is E, both A and C. The rationale is that the patient stated that they are African American and Japanese. So that is why code B, Black or African American, and code G, Japanese, would be checked. So let's move on now to another SDOH data element in section A. It's A1110, language. You can find this data element in the IRF-PAI on page 4 of the admission section and in the LCDS page 4 of the admission assessment. So here's our first practice scenario. The patient was just admitted to the facility and they communicate mostly in Spanish. The patient asked for their son to be present to interpret and assist in responding to questions from the assessor. The son confirmed that their mother's preferred language is Spanish, as very few words are spoken in English. The facility documents the need for interpreter services and arranges to have a Spanish-speaking interpreter available for the patient and assigns the patient to a care team that has at least one Spanish-speaking member. So what language would you enter in A1110A? What is your preferred language? Would you enter A, English, B, Portuguese, C, Spanish, or D, Latin? Okay, and you should see the poll coming up. And we'll give you a few moments to answer that poll. Okay, can we go ahead and move to the answer, please? Okay, excellent. About 97% of folks said Spanish, which is correct. And now, how would you code A1110B? Do you need or want an interpreter to communicate with a doctor or healthcare staff? Would you code A, code 0, no, or B, code 1, yes, or C, code 9, unable to determine? So we'll need that poll up again. And we'll give you a few moments to answer that question. And can we close the poll on this one, please? And let's move to the answer slide. The answer to this was code 1, yes, which was choice B. And about 97% of folks got that one correct. So to summarize the answers, for A1110A, the assessor would enter Spanish into the text boxes and enter code 1, yes, for A1110B. The rationale is that the patient was unable to respond to this assessment item without an interpreter. The patient's son provided the information that their mother mostly communicates in Spanish and will need an interpreter while receiving services in the facility. So we've got one more SDOH data element to review in section A, and that's A1250, transportation. You can find this data element in the IRF-PAI on page 4 of the admission section and page 18 of the discharge section, and in the LCDS, page 4 of both the admission and planned discharge assessments. So let's look at this first practice scenario for A1250. The nurse asked the patient upon admission if over the 6 months to a year, whether lack of transportation kept them from medical appointments, meetings, work, or from getting things needed for daily living. The patient stated that over the last 6 months, they did not have difficulty getting things needed for daily living, but did have difficulty getting to and from their medical appointments because they were living alone and did not have a way to get to appointments. The patient reports that after discharge, they will not have difficulty getting to their doctor's appointments because their sister will be living with them. So how would you code A1250 transportation? Would you choose A, code A, yes, it has kept me from medical appointments or from getting my medications. B, code B, yes, it has kept me from non-medical meetings, appointments, work, or from getting things that I need. Choice C, code C, no. D, code X, patient unable to respond, or E, code Y, patient declines to respond. Okay. So you should be seeing your poll in front of you. I'm just going to take a few moments here so folks can enter their answers. Okay, can we close the poll, please? Okay, and let's move to the answer. So the correct response is A, and 83% got that correct. So code A, yes, it has kept me from medical appointments or from getting my medications, would be checked. The rationale is that the patient identified that prior to admission, over the last 6 months to a year, they had difficulty getting to medical appointments. Even though the patient reports that after discharge, their sister will be moving in with them and they'll have help getting to their appointments, this information does not inform the coding of A1250, as the time period under consideration is 6 months to a year prior to admission. So let's try a second coding scenario for A1250. A patient was asked about whether they had any lack of transportation per the questions provided. The patient declined to answer any more questions and asked to be left alone. The patient does not have a proxy to respond to these questions, nor does any other resource provide information related to transportation. So based on this scenario and the response choices on this slide, how would you code A1250 transportation? Would you choose A, code A, yes, it has kept me from medical appointments or from getting my medications. B, code B, yes, it has kept me from non-medical meetings, appointments, work, or from getting things that I need. C, code C, no. D, code X, patient unable to respond, or E, code Y, patient declines to respond. Okay, I think we can close the poll on this one. Okay, great. 96% got this one correct. Let's move to the answer. So yes, the correct response is E, code Y, patient declines to respond. And that is why that would be checked. The rationale is that the patient declined to answer the question. If the patient declines to respond, you cannot code this data element based on proxy input and or medical record documentation. Only code Y would be checked if a patient declines to respond. Okay, that's great. So now we're moving on to the SDOH data element in section B, which is B1300, health literacy. You can find this data element in the IRF-PAI on page 5 of the admission section and page 19 of the discharge section, and in the LCDS on page 6 of both the admission and planned discharge assessments. So here's our practice scenario for B1300. A patient was recently hospitalized after heart attack with subsequent diagnosis of atrial fibrillation and was admitted to your facility. When asked the question regarding health literacy, the patient stated, "It was very difficult to comprehend the instructions that were given to me regarding my new warfarin medication. All the other discharge instructions I understood without a problem. I rarely had a problem before with other medication instructions, pamphlets, or other written materials from doctors and pharmacies. But this medication requires testing and adjustments that I just don't understand. So I need help with that." So based on this scenario, how would you code B1300 health literacy? Would you choose A, code 1, rarely, B, code 2, sometimes, C, code 3, often, D, code 4, always, or E, code 7, patient declines to respond? And your polling is up. I'll just give you a few moments. Okay, I think we can close the poll on this one. Okay, so let's move to the answer slide. The answer, correct response is code 1, rarely, which was choice A. And this was a little tricky. The patient stated that when discharged from the hospital, they were given instructions regarding new medication that they didn't understand, even though they reported understanding of the other discharge instructions that they were given. The patient added that prior to their hospitalization, they rarely needed help when reading instructions, pamphlets, or other written materials from doctors or pharmacies. And here's our final SDOH data element, D0700, social isolation. You can find this data element in the IRF-PAI on page 8 of the admission section and page 21 of the discharge section, and in the LCDS page 9 of both the admission and planned discharge assessments. And here's our first practice scenario on D0700. A patient was just admitted to the facility. When asked about how often they have felt lonely or isolated from those around them, the patient stated that for a time they did feel isolated, but ever since they moved in with their daughter, they have rarely felt that way. The patient is looking forward to returning to their daughter's home after discharge. So based on that scenario, how would you code D0700 social isolation? Would you choose A, code 0, never, B, code 1, rarely, C, code 2, sometimes, D, code 4, always, or E, code 8, patient unable to respond? And I see that your polling is up. So we'll take a few moments here and let you put in your answers. And can we close the poll on this one, please? And let's move to the answer slide. And the answer to this is B, code 1, rarely. And about 66% of folks got this correct. We have some split between sometimes and never. So the answer is B, code 1, rarely. And the rationale is that the patient stated that ever since they moved in with their daughter, they rarely feel lonely or isolated from those around them. So now let's move on to a few data elements that are standardized data elements, but are not looked at under the lens of social determinants of health. The first two data elements we're going to review are A2121, which is the provision of current reconciled medication list to the subsequent provider on discharge, and A2122, which is the root of the current reconciled medication list transmission to the subsequent provider. You can find these data elements in the IRF-PAI on page 18 of the discharge section and in the LCDS on page 5 of both the planned and unplanned discharge assessments. Now, remember from our recorded session that subsequent providers are based on the discharge destination location data element 44D on page 2 of the IRF-PAI in the discharge information section, and includes response codes 02 through 99. And for LTAC, subsequent providers are based on the data element A2105 discharge location, which is found on page 5 of the LCDS discharge assessments, both planned and unplanned, and include response codes again, 02 through 99. So here's our first scenario. A patient is being discharged from your facility to an acute care hospital in the same healthcare system that uses the same electronic health record, or EHR. The patient's progress notes, reconciled medication list, and transfer information is updated in the EHR by your facility at the time of discharge and can be accessed by the acute care hospital staff admitting the patient. Based on this scenario and response choices here, how would you code A2121 provision of current reconciled medication list to subsequent provider at discharge? Would you choose A, code 0, no, current reconciled medication list not provided to the subsequent provider? Code 1, yes, current reconciled medication list provided to the subsequent provider. Okay, let's move on to the answer slide and end the poll. Okay, 96% got this correct. The answer is response code B. Code 1, yes, current reconciled medication list provided to the subsequent provider. And the rationale is that having access to the patient's reconciled medication list through the same EHR system is one way to transfer important clinical information. Code 1, yes, is used for this passive means of transferring this information when sending and receiving provider can access the same EHR system. And now let's look at how you would code A2122, which is the root of the current reconciled medication list transmission to the subsequent provider. So how was this list transmitted? Will you choose A, code A, electronic health record, or B, health information exchange, or HIE, code C, verbal, which could be in person, telephone, or video conferencing, code D, paper-based, which can include fax, copies, and printouts, or code E, other methods, including texting, emails, or CDs. Okay, I think we can close the polling on this one. And let's move to the answer slide. And the correct answer is code A, electronic health record, and 96% of folks got that one correct. And so the rationale for this is that the facility and the acute care hospital share the same EHR system, and each provider can access this information directly in that shared EHR. Great. So here are our last two non-SDOH data elements in this particular section. They are A2123, provision of current reconciled medication list to patient at discharge, and A2124, root of current reconciled medication list transmission to patient. You can find these data elements in the IRF-PAI on page 18 of the discharge section, and in the LCDS on page 5 of both the planned and unplanned discharge assessments. And so remember from the recorded session that for these data elements, we're looking at whether the patient was discharged to a home setting, which would be response code 01, or not listed location, which is response code 99, as documented in item 44D, discharge destination location. And that again can be found on page 2 of the IRF-PAI in the discharge information section. And for LTACs, this information can be found in item A2105, discharge location on page 5 of the LCDS discharge assessments, both planned and unplanned. And so let's look at this scenario for these two data elements. A patient had several medications discontinued during the stay at the facility. At the time of discharge home, the patient still had an over-the-counter heartburn relief medication, as well as numerous prescription medications ordered. The nurse verbally reviewed all the medications, including the over-the-counter heartburn relief medication, and provided the current reconciled medication list in writing to the patient at the time of discharge. So how would you code A2123, provision of current reconciled medication list to the patient at discharge? Would you choose A, code 0, no? Current reconciled medication list not provided to the patient, family, or caregiver? Or B, code 1, yes. Current reconciled medication list provided to the patient, family, and or caregiver. I'll just give you a couple more seconds on this one. Okay, let's close the poll on this one. And move to the answer slide, please. So the correct response is B, code 1, yes. Current reconciled medication list provided to the patient, family, and or caregiver. And we have 99% of folks answering that one correctly. And so the rationale is, of course, that the patient was provided with the reconciled medication list. Now let's look at how you would code A2124, which is the root of the current reconciled medication list transmission to the patient. Based on the scenario, again, how would you code? Would you choose A, code A, electronic health record, B, code B, health information exchange, C, code C, verbal, D, code D, paper-based, or E, code C, verbal, and code D, paper-based? Okay, I think we can probably close the poll on this one. Okay, and let's move to the answer slide, please. And the answer is E, code C, verbal, and code D, paper-based. We have about 83% choosing E and 13 choosing D. So that one was a little tricky. So the answer of both code C, verbal, and code D, paper-based, would be checked, because remember that A2124 is a check all that apply data element. So more than one response can be checked. The rationale is that the nurse verbally reviewed the reconciled medication list with the patient, but also provided them with a paper-based copy of that reconciled medication list. So let's move on now to section B of our non-SDOH data elements. The first one that we will practice is D0200, hearing. This data element can be seen on page 5 of the IRF-PAI admission section and on page 6 of the LCDS admission assessment. So let's read through this scenario. When asked by the nurse if the patient had difficulty hearing normal conversation, the patient stated, "I've always had trouble hearing normal conversations due to some hearing loss since childhood. Thankfully, I can read lips, so that makes things easier when I'm speaking with someone. Sometimes it helps if the person talks a little bit louder, but what helps the most is if they're closer to me, speak clearly, and I can see their lips." So how would you code B0200 hearing based on that scenario? Would you choose A, code 0, adequate, B, code 1, minimal difficulty, C, code 2, moderate difficulty, or D, code 3, highly impaired? I'll give you a few seconds on this one. Okay, I think we could probably close the poll for this one. Okay, and we've got a little bit of a split here between codes 1, 2, and 3. So the correct answer is actually code 2, moderate difficulty. And the rationale here is that the patient stated that they have had hearing loss since childhood that required them to learn to read lips. The patient also stated that they can have a conversation with someone if the person sits close by, raises their voice, and speaks clearly and faces them so that they can see their lips. And our last data element is B1000, vision. This data element can be seen on page 5 of the IRF-PAI admission section and on page 6 of the LCDS admission assessment. And here's our final scenario. The nurse hands the patient a newspaper and eyeglasses and asks them to read out loud. The patient states, "Just looking at this newspaper, I can tell you that I can only see the newspaper headlines, even though I'm wearing my glasses." So the patient read the headlines out loud, but was unable to read any of the smaller text, and then put the newspaper and eyeglasses down on the nightstand next to the chair. So based on this scenario, how would you code B1000, vision? Would you choose A, code 0, adequate, B, code 1, impaired, C, code 2, moderately impaired, D, code 3, highly impaired, or E, code 4, severely impaired? So I see that your poll is up. And we'll give you a few moments for this one. Okay, I think we can close the poll on this one. And so again, we've got a little bit of a split between codes 1, 2, and 3, with 38% choosing code 3, 36% choosing code 1, which is the correct answer, as you see here on the answer slide. So the answer is code 1, impaired. And the rationale is that the patient demonstrated that they were not able to read any print other than the headlines in the newspaper. And because the patient put the newspaper and glasses down on the nightstand, this demonstrates that the patient can identify objects in the environment. So this brings us to the end of the coding workshop for the SDOH and non-SDOH data elements in sections A, B, and D. But before we move on, I'd like to review some key insights related to the data elements we reviewed as part of this workshop. So we learned that SDOH affect a wide range of health risks and outcomes and are important factors to consider when collecting patient data. Collecting this data is an important step in improving quality of care and health outcomes. In terms of transportation, access is essential to effective care management and can facilitate the patient's connection to the community. Poor health literacy interferes with communication between provider and patient and is linked to poor outcomes. It is also linked to higher medical costs, decreases in accessing preventive services, and increases in emergency department use. Social isolation increases with age and is a risk factor for physical and mental illness, as well as being a predictor of mortality. We also had an insight that ensuring that a current reconciled medication list is provided to a subsequent provider and or a patient at the time of discharge, and that this is critical to ensure safe and effective transitions of care. And unaddressed communication problems related to hearing can sometimes be mistaken for confusion or cognitive impairment. And hearing or vision impairment can contribute to sensory deprivation, which can limit the enjoyment of a patient's everyday life. This in turn can contribute to social isolation, which can lead to mood and behavior disorders. So I want to thank you so much for your time and your attention today, and have a great rest of your day.